Uh, Good morning, everyone. So we wanted to divide this CGR into two portions. The first portion is the description of type of emergencies that we deal with and some representative cases. And then following that, we are going to present an audit. Dr. Munshi, who is the youngest faculty member of our department, joined last year, is going to present this data. Thank you.
Okay, so as Sir has described, today's topic is emergency surgical procedure in cardiovascular and thoracic surgery. So it is an audit. First part will be some interesting cases, and second part will be the data audit. So how we are going to divide the emergencies? So we are going to divide emergencies as acute and subacute. In acute, we will be seeing cath lab device failures, where we need immediate intervention, and vascular emergency. Where subacute, we will divide into aortic dissection, complications of MI, then refractory angina and post-angina cases, and congenital heart disease, where we required salvage procedures. And last but not the least, valve diseases with infective endocarditis. So cath lab device failure can be further divided into percutaneous device failure for ASD, VSD, and PDA. Then aortic regurgitation and mitral regurgitation resulting from balloon valvotomies that are being done for AS and MS. Then emergencies resulting from pacemaker lead placements that causes injury to the vital structures in the heart. Then coronary interventions leading to the dissection and rupture of coronaries.
So these are the situations where we have to act immediately and take the patient to the OT and actually operate. So in this, interdepartmental coordination is very important. And with that, we need a quick response time because we don't have a hybrid OT where these cases can be taken. And last but not the least is financial preparedness. So we had total 5 cases. Among these 5 cases, 3 were ASD device closure, 1 was RSOV device closure, and 1 was VMV. So in these 3, we did ASD patch closures, and 1 was RSOV closure, 1 was mitral valve replacement. The good thing was all the 5 patients were saved. So 100% survival with good follow-up. All 5 patients are under follow-up and asymptomatic currently. Here, we must mention the team. It was possible because of the team effort, coordination between cardiologist, anesthetist, and cardiac surgeon. At the same time, our institute has certain policies for such emergency cases where we don't have to worry about the monetary issues. So these are some representative angios. So here, Amplide's ASD device is getting deployed. Now it is deployed at its correct position. And now we will see it will migrate into RV. So here is the device. It has migrated. Okay. Similarly here, the device is not deployed yet. Here is the device. Same, amplifies the device. Now it is deployed into its correct position. And now it is migrated into pulmonary artery. It's here. Sorry for the bad visuals. So here it has migrated into pulmonary artery. Now, next heading is vascular emergencies. So basically, vascular emergencies include traumatic vascular injuries, rupture of pseudoaneurysm, iatrogenic injuries, and intraoperative injuries to major vascular trunks. In these cases, we have to hurry because the patient may bleed a lot, and because of the blood loss, there may be risk to life. Here I'm going to present a representative case. This was a fine non-working afternoon where we got a call that 21-year-old female with CKD had, by mistake placement of dialysis catheter into carotid artery. So initially it was not clear whether it is only inside the carotid artery or something else is damaged. So we decided not to pull it out and to surgically correct the rent in carotid artery. Plus this was 11.5 or 12 French, that is too big rent. We cannot just pull out and bleeding will stop. So we took the patient immediately within 2 hours time. Dr. Manas was in coordination from nephro, and that was a great effort. We don't have to, worry about the shifting and all. From anesthesia team, everyone was ready. So as we took the patient within 15-20 minutes, we went to the rent. We realized that it was going through and through from internal jugular vein to the carotid artery, and it was going up to the arch of aorta. That was visible on CT. So in this case, if we could have pulled the catheter and compressed it, there were chances of major catastrophes like bleeding, in future pseudoaneurysm, and AV fistula because it had gone through and through from vein to the artery. And last but not the least, compartment syndrome in this neck. Patient was awake, not intubated. Compressing hard in that case could have resulted in major catastrophes. So we corrected the venous rent as well as arterial rent, and patient is fine now. Now we'll come to the subacute emergency. The first foremost is aortic dissection. Type A aortic dissection, stand for type A, is the acute emergency. Type B can be managed medically. Now, I feel everyone is aware of aortic dissection. In aortic dissection, there's a rent in intima which opens into media, and it seeps into the media and it divides in unequally. Now, this media can rupture on the surface, and this media keeps on elevating a plane. That plane can go into any of the major arteries. So this is the actual lumen, and this is the false lumen that is generated. And there is a communication between true lumen and false lumen. So blood goes from here, and then it suppresses the true lumen. So distal to this area, the blood circulation to organs are compromised. If it goes into the carotid, it will compromise blood circulation to the brain. If it goes into coronary, it will compromise blood circulation to the heart. And if this tear goes proximally, it can cause acute aortic regurgitation. That is also an acute catastrophe. So that's why we have to operate this patient on emergency basis. Next category is post-myocardial infarct, VSD. Now, post-myocardial infarct, major mechanical complication includes post-myocardial infarct, VSD, mitral regurgitation, and free wall rupture. So VSD presents 0.5 to 2% of total acute MI, while it contributes to the 5% of total death in post-MI. It includes elderly female, non-smoker. Basically, this includes a group of patients who are not being exposed to the ischemia earlier. This is their first exposure to ischemia, and it resulted into a total occlusion of a single vessel. So that single vessel territory dies completely and makes a hole into the muscle that acts as a ventricular septal defect. So the outcome depends on four main factors. First is size of infarct. Second is shunt. Now, because there is an acute VSD, there will be shunt left to right. So the ratio of that shunt is very important. Third, ventricular dysfunction because of that shunt. And fourth, but most important, when the patient is presenting after the insult, after how many days? Now, if I say about median time of symptom, from the insult to 1 day, the symptoms start deteriorating. And from 1 to 5 days, the mortality goes on increasing. So if I say the balance between the risk factors, the most important is time of presentation of patient in hospital. Why? Because as the shunts develop from left to right, the lungs will deteriorate. Because of the lung, As the lungs will deteriorate, the total perfusion to organs will deteriorate, as well as the right ventricle will start deteriorating. As the organ perfusion deteriorate with time, the overall recovery capacity of the patient will deteriorate. This paper of ATS 2008, as you can see this curve, the mortality is nearly 40% within a week's time. So within 7 days, 40% patient will die. In 2 to 3 weeks, nearly 80% patients will die. And at the end of the month, the mortality is 100% if there is no surgical intervention. While if we operate within 7 days of primary insult, the mortality is 54%. When surgery is done more than 7 days, the mortality is less, but there's a catch in it. This 7 day is if patient present right at the time of insult. So if right at the time of insult, patient come to the hospital, if patient is optimized properly, then only these results can be seen. Otherwise, it will take this pathway of 40% death within 7 days. So earlier, the AHA guideline used to say that we have to operate as soon as possible as patient comes to the hospital. But now they have improvised. They said that we have to optimize patient first, and then we have to see the hemodynamics. If patient is hemodynamically stable, then we can delay the surgery up to 7 days, but then we have to operate. This is a European Heart Journal 2014 article presentation. It says the same. So if patient is hemodynamically unstable and comes to hospital, then what options we have? Either we can take immediately for surgery, we can give on mechanical circulatory support, that is ECMO, or as the patient won't tolerate the surgery in this condition, we can attempt for percutaneous closure. So that is the least we can do by giving minimum harm. Otherwise, if we operate these patients, the mortality is certain. Then second group, they have said that patients are hemodynamically stable, but with large VSR. So what it means by large VSR is left to right ratio. So what large VSR will do, it will further deteriorate lung, further deteriorate perfusion. So multi-organ failure will set up faster. In that case, we can put IABP and ECMO. What IABP and ECMO does, I will tell you in further slides. And third category is hemodynamically stable with small VSR. Now in this graph, you must be thinking what makes them live, the 60% live beyond 7 days and 20% live beyond 21 days. So again, these are these factors: size of infarct, shunt, and RV dysfunction. So if size of infarct is small, shunt is less, then the chances are there that patient will be stable. In such patient, we can further optimize the patient and we can wait as much as possible so that the surgery is delayed and we can try for percutaneous closure or surgical management. So the key in post-infarct ventricular septal rupture is optimize the patient, wait as much as possible within limits, and then operate. And why this is important, why we have to wait as much as possible. Sorry, this diagram is not that clear, but you can see this is a large infarct and the margins of infarct are ragged and they are plethoric when this infarct is happening. So when we are operating, the major challenge for surgeon in VSR is to have a rim where he can put a suture and that won't give off. So once this challenge is tackled, the result will be good. So this rim to fibrose and become strengthened, it takes time. And any fibrosis takes 3 to 4 weeks. So that's why this flowchart is put down and divided into 3. Now, as I told you earlier, I'll explain about ECMO and IABP. So what are our tools of optimization in such patient? First is intra-aortic balloon pump. So what is intra-aortic balloon pump? It's a console with a catheter going into the aorta, and there's a balloon inside the aorta through this catheter, which inflates during diastole. What it does, it displaces a blood volume during diastole into the major vessels. So this is our systolic pulse wave, and this is the balloon-induced diastolic pulse wave. So what it does is increases blood circulation as well as reduces the afterload. This reduced afterload reduces systemic vascular resistance and reduces your left to right shunt. Second option is ECMO. What ECMO does is it reduces preload. It takes blood from the jugular vein, oxygenates it, and puts into femoral artery. Then biventricular assist device. The difference between biventricular, it does the same. What it does, it reduces preload and gives the circulation to the afterload, the arteries. So biventricular means for RV, it takes blood from RA and gives into pulmonary artery. But here, the lungs oxygenates the blood, not the oxygenator. For left side, it takes blood from LA and give it to aorta. Last three options are medical options. That includes diuretic, dialysis if to reduce the load if creatinine is high, and inodilators if blood pressure permits. Inodilators because we have to reduce the systemic vascular resistance. So this was a representative diagram of ECMO, and that is our ECMO BioVAD machine. This is a representative diagram of BioVAD. Now, our experience in emergency cases of VSR, we had 3 patients, out of which 1 survived. Of course, the 2 who couldn't make were not in that window of optimization. They presented a little late with multi-organ failure. Even after surgery, we could extubate them on post-op day 2, but as there was multi-organ failure was setting in, we had to re-intubate and we lost the patient. Now, post-myocardial infarction, mitral regurgitation. Now, when a septum is infarcted, it will present as VSR. When vascular supply of papillary muscle has gone, it will present as a mitral regurgitation. So it can present in 3 forms. Very acute, so it will present as acute MR. It can be slow, and it can involve the wall in which papillary muscle is inserted. So there will be wall motion abnormality leading to dysfunction of papillary muscle resulting into the MR. That won't present that acute. Third will be annular dilatation. That will be very slow. So acute MR after MI is about 1% of the total MI outcome. The acuteness of MR depend upon whether the papillary muscle has ruptured completely or not. On an average, 50% die within 24 hours and 80% within 2 weeks. But if the rupture is complete, nearly 60%, 66%, 1/3 die within 24 hours. Again, it is associated with single vessel disease. This is one of the representative case. This 53-year-old female presented in cardiology. So here we can see L6 territory acutely cut off. This is LCX suddenly cut off. So this is total occlusion of LCX leading to the complete rupture of papillary muscle. We took this patient. We kept her on intra-aortic balloon pump and operated nearly 5-6 days later as emergency. This was a pre-operative echo. You can see the papillary muscle is dangling. There's a free papillary muscle. It is ruptured papillary muscle. We could extubate the patient on post-op day 2 with a balloon pump support, and patient went home. Currently, patient is doing fine. Last entity is ventricular free wall rupture. Now, this is very rare entity because most of the patients don't make it to the hospital. It is like a rupture in a balloon. So when free wall ruptures, the blood seeps into the pericardium, creates tamponade, and there is sudden death. So now here the survival depends whether pericardium is free or it is adhered to the myocardium. If pericardium is adhered to the myocardium, the leakage won't be that fast, and patient will present as pseudoaneurysm, and the symptoms will appear gradually, but not that slow. So it all depends upon the pericardium, whether it is free or adherent, but death will also be faster in both the conditions. One important thing, we should not thrombolize in this patient, because if we thrombolize, the myocardium which is holding will degenerate faster and the defect will increase in size if it is small. Last category in MI is refractory angina or post-MI angina. In simple word, if I say a patient who has an acute MI or patient who is a known disease, known patient of coronary artery disease, but getting recurrent attacks, so acute and chronic. So when should we operate these patients? So preferably we should avoid in first 7 days. And if we can avoid till 6 weeks, it will be better. Now, why? Because in first 7 days, the myocardium is hyperemic, irritable. And because of that, the result won't be good. Intraoperatively, we have seen that many a times patients behave very bad. There are multiple ventricular tachycardias because myocardium is irritable. So what we should do in this patient? We should wait, we should optimize, we should keep patient on heparin. And we have to take a balance again, like VSR, that when we can operate, we can wait. We have to actually assess the patient on daily basis, whether the patient is improving or not. And then we have to decide whether we should operate or not. So what are the factors which will say that we have to operate early? If there are imminent of complications of MI, if the MI is increasing every day, how will we come to know that? We have to keep assessing troponin level. If troponin level, chest pain, ECG changes persist, troponin levels are going up, then we should put a balloon, deflate the heart, give some mechanical support, and then operate. This is one of the representative patient. This was 81-year-old male. He was referred from outside. I think he was referred from BHU. So right coronary artery, 90%, left coronary artery, 90%. So God only knows from where the blood was coming. This was the echo. As you can say, all orange and red shades into left atrium. So patient was having ejection fraction nearly 40% and moderate to severe MR. So these are very challenging conditions for a surgeon to operate. And see, operating is not important. The outcome is always important. We operated this patient. We did the total arterial revascularization after a month. So we waited for a month. We assessed patient every day. We optimized patient. What happened? At the end of the month, the severe MR had come to mild to moderate, and ejection fraction also improved by 5%. And this is the post-op echo. So here, hardly trivial to mild MR, and ejection fraction maybe nearly 50%, seeing the video. So again, one more thing, we didn't need intra-aortic balloon pump support in this case. Now, our major challenge during this period was congenital heart surgery, in which patient required salvage surgery. First, I'm giving you a representative case. This was a 8-month-old child with RA rhabdomyoma. Initially, it was known as RA mass only. On histopath, it came as a rhabdomyoma. It was a 5-centimeter mass for an 8-month kid. You can see there is no RA. There is only tumor. This RA, this is tricuspid bone. Only tumor, this huge tumor he was carrying. There was hardly any output from right side. Patient presented on Sunday evening. We operated Monday morning. This is the heart. This is the head side. This is the leg side. So hardly it is moving. This whole thing is a tumor trying to pop up. And this is the tumor after surgery, nearly 5.5 centimeters. This is the cut section. The patient survived and still in follow-up without any symptoms. So this is our data of those 5 surgery. Out of 5, 2 survived. 3 we couldn't save. Now I would like to highlight certain things. These three were complex congenital heart diseases, and these were salvage surgeries. All 3 patients were on ventilator. All 3 patients had average CRP ranging 50. So the range of CRP was 50 to 150. So they were persistently under infection, and we were trying to find a safe window where we can operate. Why I'm saying all these things, you will come to know when I will analyze the data. So so these 2 patients of PDA ligation, this was non-ventilated on room air. This RA rhabdomyoma, we have seen the tumor, how big it was, but even then lungs were not that bad. So the outcome was good. So what are the problems we are facing currently in emergency congenital cases? First, evaluation and management of pulmonary hypertension. So most of the congenital heart cases are either VSD, where there is increased blood flow. So here, evaluation of pulmonary hypertension is very important. Any patient who is having moderate to severe pulmonary hypertension, we operate and close the defect, the patient won't be able to come off the pump. Second is, we need to know the anatomy. A 15-day-old kid or 30-day-old kid with heart rate at 150, 160, 2D echo won't tell you most of the things. So here we need a contrast CT to see, first of all, what anatomy we are dealing with. Without knowing anatomy, we won't be able to give any correction. Third, in post-op period, the temperature control. A cardiac ICU believes in keeping temperature low, where for NICU or for neonates, we need higher temperatures. Last but not the least, persistent underlying infection. This patient with plethoric lungs, they are very prone to infection. Their CRPs are constantly high. If we wait, there will be multi-organ dysfunction because of the hyperemia to lungs. And if we operate with infection, the inflammation will kill the patient. So what solutions we built up? So first of all, of course, one brain can think some things. Many brain can think many things. So that's why a team approach is very important. So now we started actively involving CCM, NICU, radiology, cardiology, and anesthesia, of course, for every step. When patient comes, the consultation to all these departments are being sent, except radiology. We just give consultation for imaging study if any needed, and their opinion has been taken. Then for countering pulmonary artery hypertension, we have a new machine for inhalated nitric oxide. Nitric oxide helps in relieving pulmonary hypertension. How it helped us, I will tell you in next slide. Third thing, early transfer of such patients to ICU. Once the surgical issues are settled, we started transferring this patient to NICU as soon as possible because they are good in weaning off the patient from ventilator. Last is better optimization preoperatively for infection. Our major enemy in on-pump surgery is infection and inflammation. So if we could optimize the patient with the help of everyone and get that safer windows earlier, then the outcomes will be better. So 7 days back, we operated on this patient, 45 days old, 3 kg weight patient with TAPVC. Now, what is TAPVC? It is, the problem is the pulmonary drainage is not into LA. It goes back into the venous system on right side. So this is a representative diagram of TAPVC. This is a patient's actual MRI. So with the help of MRI, we could know what is the anatomy. We operated the patient. This patient was having moderate to severe PH. Because of the pH, we were not able to get the patient off pump. So what we did, we got a new INO machine, that is inspiratory nitric oxide. With the help of INO, the pH was settled and we could wean off the patient from pump. But still, there was too much of edema on heart. The heart was swollen and pH was not completely down. So heart was popping out of the chest cavity. So we kept the chest open. We shifted with open chest to the ICU. We continued nitric oxide. Within 24 hours, the things settled. The edema settled, the pH settled with help of nitric oxide. We closed chest on post-op day 1. After closure, we weaned off the nitric oxide till post-op day 2. But at post-op day 2, we started getting signs of inflammation and infection. So what we did, after drain removal, we shifted the patient to NICU. And there, as they are good in managing such patient of 45 days and 50 days, they are trying to wean the patient, and patient is on HFO. Patient, of course, has improved from this stage to this stage. So this all happened because of our inherited nitric oxide. Otherwise, this was a dead end with moderate to severe PAH. This is the mechanism of, I know this is the machine of inherited nitric oxide that we got. So now I will come to the data part. So we collected data from June 22 to October 2024. This is retrospective data collection. We operated 70 emergency cases. So data was collected from for demographic and operation information purpose from HIS. And we tried to utilize as many parameters we had for knowing the inflammation status and organ function status. So we could collect data like LFTs, RFTs, TLC and NL ratio. TLC and NL ratio for inflammation and rest of the parameters for organ function. So out of 70, mean age was 41, male to female. Male to female ratio was 37 to 33. 29% were CABG, 18% were MVR, 7% ASD, and likewise. This slide shows from where we received the patient in emergency. So major chunk was from MICU, then cardiology ward, cath lab. The purpose to show this slide is these patients we took and optimized and then operated. While from NICU, as we are not as good optimizing a neonatal patient, they optimized the patient and shifted to the CVTS. Then the mortality percentage was 27 among these 70 patients. Out of these, you can say maximum mortality was in neonate. Those numbers are less, 60%. Then, and the reasons I have already explained. Then in valve cases, the CABG cases 29 and valve cases 26%. This is a elective mortality. Here, I showed you the emergency mortality that was nearly 27%. This is our elective mortality, that is 4.34%. Now, if I like to take some message out of the data, I have to process the data. So first, I tried finding out parameters which are significant. Out of all these parameters, which are significant. So I compared them in pre-op and post-op groups. So I found that TLC and neutrophil ratio are directly significant if I compare it as a pre-op and post-op group. Then I compared same data in live and mortality group, same parameters. So if I compare with live and mortality group, the significance was for creatinine in post-op and neutrophil lymphocyte ratio in both pre-op and post-op. So this significance, we have to bring a correlation to the significance. So when I correlated for post-op NL ratio, there was a positive correlation with mortality, as well as post-op creatinine was having positive correlation with mortality. And this correlation was significant. If I put a ROC curve of this, for NL ratio, with 100% sensitivity and 86% specificity, was at NL ratio 2.56. So here it says that NL ratio directly reflects your survival of patient after surgery or mortality of patient after surgery. Now, if I try to put same thing for optimization. Now, how we defined optimization in this case, we went through the investigation and then we came to know that if we put 5 days from the admission. If patient was taken after 5 days of admission and optimized, we put those patients into optimized group, and unoptimized patient we put in non-optimized group within 5 days. We couldn't find any significance when compared with optimization. But if you see the numbers are promising. So total number, optimized patient 16, mortality was 4 for CABG. For CABG unoptimized patient, for number 8, the mortality was 3. So if you see percentage, of course, optimized is better. But because the sample was very mosaic and small, the significance is not reflecting. So for significance, we need larger sample, larger studies. Same with valve. Optimized, though it is 0, mortality is 0 against 15 and 4 against 8. So numbers are, it's like infinity versus 50%. But because the sample size is very small, the significance is just away. So 0.05, we are getting 0.08. So actually the sample size is very small. And in that 70 patients, we had nearly every category. So that's why, because of small sample size, significance we cannot gauge for optimization. The same I have plotted for bar chart. Okay. This one is for wall. There was no mortality as well, no green. Now, limitation of our audit. First, we analyze multiple procedures for small numbers, 70 number against some 11, 12 procedures. Then data of patient admitted in cardiology and not operated. Patient who couldn't make the table, and patient who went somewhere else or something else and not operated, not transferred to the CVTS is missing. So that's why this study is incomplete. There were no specific parameters available for inflammatory and organ function. Actually, CRP and there are finer measures for reflecting inflammation. But we took whatever available, and for us only NL ratio and CBC was available. So that's why we are not taking best investigation report to define inflammation. Again, data was missing for some patient due to urgency of surgery. Patient directly landed and we had to operate without proper reports and all. So that's why for some patient data was also missing. Now I will come to the final message, that is audit point. So what we concluded with this audit. Why we did this audit, already explained. Now what came out of this audit? So we realized that for our cath lab emergencies, our policies are good. They are holding good. We are giving 100% result. So we should go with these policies. Then for neonate, we have to optimize our coordination with rest of the teams, NICU, cardiology, radiology, and CCM, so that the outcome will improve. Third, as with introduction of inhalatory NO, we are getting result. We should start using it more frequent, and we have to see in how many ways we can use it for a positive result. Third, we have to increase ICU staff ratio. 1:1 ratio should be there to avoid cross-infection, for better attentiveness for the patient. Last, but the most important, infection control. Because our major challenge for congenital surgeries was infection control and inflammation. For adults, again, coordination between the departments, especially with cardiology department, so that we can optimize the patient in a better way and we can improve our results. Then more appropriate and frequent use of mechanical circulatory support device. By frequent, I don't mean for every patient, but we have to discuss that which stage and which patient need this intervention. And whenever it is required, patient should be shifted to CVTS, and then as soon as possible, the mechanical circulatory support should be started. What mechanical circulatory support devices we have? We have balloons since ever. We have ECMO available since last 2 years. We have ventricular assist device since last 6 months. Then the most important, inflammation and infection. We have to control factors which are causing increased inflammation and infection both pre-op and post-op. So that includes a proper infection control policies. Last but not least, optimization, of course, means a longer stay, more intervention, So for that, patient need to have a financial backup. And how to create this financial backup, we have to discuss with administration and we have to come up with a policy. That's all. Thank you.